Greetings everyone. Today we will be seeing about a very common medical condition, intertrigo in a diabetic foot patients, and how to deal with them surgically. So to quote a case study example, this patient is a 65-year-old diabetic female patient who presented over a period of 3 years with multiple problems and corrective surgeries. First, she had a Keller's gap arthroplasty for an IPJ ulcer that got corrected, and subsequently she had a tiptoe osteomyelitic ulcer, had to go for an amputation. So subsequently, when she developed a tiptoe callosity and ulcer in the left second toe, she immediately came around and then we did a long flexor tenotomy. And if you can see in this procedure, picture, the callosity and ulcer has completely healed. But she had a severe intertrigo in both the feet, in both the fourth and fifth web spaces around May 2022. So for which we have taken up the patient for long flexor tenotomy. So, an overview about intertrigo, as we all know, intertrigo is an inflammation in the skin creases. Wherever there is a friction areas where moisture accumulates, the patient develops a fungal infection invariably. So, in the foot, why it is predisposed is because of the anatomy of the long flexors. As you see, the long flexors they come into the foot as a bunch and then they spread out into the each individual toes. So when the long flexors contract, not only the toes go in for flexion, but they also go in for a crowding. In addition, the lumbricals which are attached to the long flexor tendons, they have an origin from there and they are also inserted into the inner sides of the toes. So they also contribute to the crowding of the toes. So subsequently, they go in for intertrigo development. Why this intertrigo in a diabetic foot is very important is this can turn into a catastrophic incidence because the web space is an area where all the four layers of the feet meet together. So as an infection around this area can subsequently spread to all the layers of the foot easily and can become an ascending sepsis. And also it can cause a septic thrombosis of the digital vessels and can easily lead on to a toe amputations. So the procedure long flexor tenotomy is basically severing the long flexor at the mid phalanx level so that the terminal flexion of the distal phalanx is taken off. So this can be done by simultaneously extending the distantophalangeal joint and giving a pressure on the dorsum of PIP joint so that as you see in this picture the long flexor just comes superficial and comes to lie below the skin. So it can easily be approached by a percutaneous technique by using a needle and it can be severe. So this particular patient, the problem was this is intertrigo is so severe and it is right there at the point of entry of the needle. So ideally speaking, this should have been gone for an open flexor tenotomy in a proximal incision and where we can identify the tendon and give a direct cut of the tendon under vision. But we tried a percutaneous approach a little proximal than usual and we could get away with this. But generally speaking, the percutaneous is the dictum whenever you are contemplating long flexor tenotomy. The role of open procedure is very minimal. If at all the open procedure is to be contemplated for a flexed tendon, then it has to be through a Z-plasty incision so that the skin contracture also gets simultaneously relieved. With the percutaneous approach, even though we release a tendon, the skin that is tight over a long period of years together takes about 3 to 6 weeks time for it to stretch out, but it does get stretched out with the patient subsequently walking. So in this particular case, we decided to go for a percutaneous attempt. So as you see in this picture, this is the anesthesia. Normally, most of these patients have severe neuropathy, so they don't feel the needle prick, but it still give a little bit of lignocaine by using a 31 gauge needle. And as you see, the fourth toe of long flexor tenotomy has already been done, and the fifth toe we are entering a little proximal than the usual approach. And once I feel the tendon, because it is a little proximal than usual, it's a bit difficult to feel the tendon. And as you do the procedure, you will gain experience in the feel of it. The tendon giving way, there will be a classical snap and the feel, and you can immediately appreciate the DIP going in for an extension. So as you see, the rocking motion should happen at the wrist level, and once you get to feel the snap, you can extend the tendon. So this is the testing the release effectively. So as you see the fourth toe, the DIP joint is freely moving, and the fifth toe. When you compare with the normal toe, the second toe, you see the amount of resistance that the patient throws in when you ask them to flex the toes completely. The thumb, you can appreciate the amount of resistance that is given to the thumb as against the fourth toe that you can easily extend at the DAP joint, and the fifth toe also. So this is the way you test it immediately after the procedure. And these are the results in both the feet. About 2.5 to 3 months later, the patient came back, and you can see there is a complete clearing of the intertrigo in both the feet, both the web spaces in both the feet. Normally, this clearing happens even earlier than that, around 5 to 6 weeks itself. You can see a complete clearing of the intertrigo. So, a word about long flexor tenotomy. The most common indication for long flexor tenotomy are the tiptoe ulcers. As you see in this picture, this patient came with the second tiptoe ulcer, which was probing to bone with osteomyelitic focus. So, we had to go in for an amputation and shorten the toe. But at the same time, we also address the callosities as well as subdermal hemorrhage and the predisposing, the forerunner for trophic ulcers in all the other toes with the long flexor tenotomy. You can appreciate the post-op picture where all the toes are straight and all the callosities are completely disappeared. If this has not been done prophylactically, the patient would have ended up with the transfer ulcers subsequently in each of the toes, and each of the toes would have gone for the same eventuality as that of the second toe ulcer. So, long flexor tenotomy is also indicated for dorsal ulcers over the IP joints in a severe claw deformity, where this brace hits against the footwear and the patient may develop an ulcer. And this also indicated for torsion ulcers that occur on the sides of the little toe as well as the great toe. So, long flexor tenotomy is a very simple, easy procedure that you can learn effectively over a short period of time, and it's a cheaper procedure. There are no major contraindication, even in the patient in the peripheral vascular disease or those who are on aspirin or clopidogrel also. This procedure can be safely done, and this gives immediate results. The downtime for achieving the results is very good. The ulcers heal almost within 4 to 6 weeks, and what it does is it provides confidence to the patient that this kind of an offloading procedures definitely works, so that subsequently when they have other major issues, they become very compliant to surgical procedures as well as offloading footwears. So detecting these patients in early stages and doing prophylactic and preventive surgeries goes a long way in saving foot and preventing amputations. Thank you for your patient listening.